Hi, welcome back to the Paramedic Project. Thanks for joining us one more time today. Joining me, guest presenter, friend of mine, friend of the show, Dr. Fran Williamson.
How are you?
Really well, emergency physician here in Brisbane and an emergency doctor with lots of pre-hospital experience, especially dealing with traumatised patients. So I thought, given that we've done some recent episodes on the basic medical cardiac arrest, it'd be great to talk to her about her experience with the traumatic arrest patient. So, Fran, I suppose big first questions for me approaching these scenes. How do you approach the scenes? What are your thought processes? How do you approach them?
Yeah, so I think the time when you're arriving on scene is really valuable. It's a time to reflect on what the potential causes of the arrest might be. Certainly, while we're talking about trauma cardiac arrest today, we still need to remember that medical cardiac arrests still occur in this population.
Sure.
And so certainly getting a lot of information back from the scene can help me risk stratify and just prioritise what my immediate needs will be when I arrive on scene.
Yeah, sure. And do you break your thinking down into penetrating trauma, blunt trauma? Is that kind of the thought process for you on the way to the scene, or?
Yeah, certainly. Yeah. So obviously the management of blunt versus penetrating traumatic arrest is completely different, so that's very valuable information. But I think it even starts further back from that, knowing some demographics about the patient, knowing the mechanism of injury, and knowing the circumstance in which case the accident occurred is incredibly valuable. I'm obviously going to prioritise the patient who's a 20-year-old patient who's in a high-speed MVA, who's entrapped on scene. In my mind, that says trauma.
Okay.
Versus the 70-year-old patient who's just gradually veered off the road into a ditch with no damage to the car. I'm going to be thinking about medical causes, and so my priorities and what I assess and then do for the patient in primary management are going to differ.
Yeah, sure. And we sort of mentioned before, there have been some real-time examples of those types of cases floating around in our kind of pre-hospital environment where we've both worked. So you have those cases come up every now and again that initially get dispatched as a traumatic arrest, but then just based on demographic information, your ideas around the case changes, and then the real-time information you get on scene changes your ideas around how you're going to manage that patient as well.
Yeah, certainly. Yeah. I can remember a case where the initial call-out was for a traumatic cardiac arrest, but when we arrived on scene, it was very clear that in this elderly patient with absolutely no damage to the car, despite being on a motorway, that this was a primary medical event.
Yeah, sure. Okay, so first of all, demographic information, then information on mechanism of injury, and then obviously we're getting some real-time information once we get on scene as well, and that's really starting to, I suppose, outline the priorities of the patient's care to us as well.
Yeah, and what's happened to the patient to date? You know, have they had any bystander CPR? Have they had any bystander attention? And what the first crew have done for them?
Great. Okay, so that's the first little snippet on traumatic arrest patients. Find us on social media, it's been Paramedic Project, and we'll go on to more episodes just touching on some big key points on the management of the traumatised patient, just the next coming episodes as well. Thanks for joining us once again.